Hi there, this is Aaron Filler. I'm a neurosurgeon in Santa Monica, California, and this PowerPoint concerns Chapter 286, Pain, Complications, and Iatrogenic Injury in Nerve Surgery. So this chapter brings together several issues. At one level, describing the categories of pain that can result from nerve injuries. Secondly, discussing common complications of peripheral nerve surgeries, and then more generally, common iatrogenic nerve injuries that a neurosurgeon may be called upon to help with in terms of repairs. Considering for all of these, what are steps that can be taken to reduce the occurrence of complications in the course of surgical treatments. In the categories of pain, I want to distinguish neuropathic pain, neuritis, neuroma pain, discuss complex regional pain syndromes, avulsion pain, and musculoskeletal pain. In the area of common complications of peripheral nerve surgeries, I'll talk about problems in the brachial plexus, the median nerve at the carpal tunnel, the ulnar nerve at the cubital tunnel, and elements of concern during resection of nerve sheath tumors. Then, as the third segment, I'll go through and talk about some of the common iatrogenic nerve injuries that may be referred to a neurosurgeon. These will arise in, for example, the spinal accessory nerve, the ilioinguinal nerve, sciatic nerve, peroneal nerve, ulnar nerve, lateral femoral cutaneous nerve, the brachial plexus, and the lumbosacral plexus. Now, I'm going to run through some different categories of pain that can result from nerve injuries. Firstly, neuropathic pain, typically burning with allodynia, that is all types of sensation being perceived as pain, hyperesthesia, increased sensitivity with some burning. This is really a general term for a nerve injury pain, that is pain arising from the injury nerve rather than a situation where a particular body part is injured and the nerve is merely reporting pain arising from a particular part of the body. And these typically relate to peripheral nerve injury, compression, or ischemia. Neuritis is more of a sharp pain or electrical type distribution in terms of the perception of it, and will more commonly relate to a single peripheral nerve segment. And it is a subtype of neuropathic or neuralgic pain, but it is worthwhile in treating this type of problem to consider the cause of the neuritis. For instance, an autoimmune neuritis may respond to immune suppressive medications such as Singulair, or cyclosporin, or even Enbrel or Humira. Reinnervation pain, and this is often a positive result of correcting a severe nerve compression, but there would be electrical tingling pain, twitching, shocks, but as long as you're aware that this is arising from a recovering nerve compression, nerve injury, it's worthwhile just to encourage the patient that although it's uncomfortable, it's a positive sign of a nerve waking up. The very acute version of this that many people are familiar with is when a nerve goes to sleep, as we say, due to pressure, and then we relieve the pressure, there may be a discomfort, and this can take place over a period of a couple of months after surgical relief of a severe nerve impingement. Neuroma pain can be an extremely intense and impossible to manage pain. There are aspects of neuroma pain which may be treatable, so that, for instance, a severed nerve may result in a terminal neuroma, which is a ball of very sensitive nerve tissue. And if this is fixated tissue, or even worse, fixated over bone, any movement of surrounding tissue will pull the neuroma against the hard surface and continually trigger intense pain. This has the problem that one treatment may be to resect the neuroma, and the unfortunate possible consequence that another neuroma forms behind it. And this is one reason why patients should be advised that with severe pain, simply cutting a nerve is not a solution and may make it worse. And so it should be reserved, because once it's done, there's no undoing it. A good general recommendation is to first try neuroplasty, releasing or freeing a nerve to try to relieve the pain before considering nerve resection, even though some older advice may include going direct to nerve resection, such as for the ilioinguinal nerve. This is not a good choice because you can make the problem much worse by a nerve resection. Avulsion pain is this difficult situation where you have, for instance, a pullout of a nerve rootlet from the spinal cord. The only types of intervention that may help would be a dorsal root entry zone lesion ablation and or spinal cord stimulation. This is a crushing, burning, or freezing pain which can generally be expected to be limited to a distal portion of a limb or in the distribution of the nerve that's avulsed. CRPS, or complex regional pain syndrome type 1, is generally believed to be sympathetic in origin, and this has the older name of reflex sympathetic dystrophy. Typically, there'll be burning, allodynia, hyperpathic pain, often in a single nerve distribution, without a corresponding evidence of nerve injury. To the extent it may be sympathetically mediated, it's well worthwhile to try to consider what sympathetic ganglion is involved and to then carry out a block of that ganglion with anesthetic to further attempt to verify the source. Injections with anesthetic, steroid, and hyaluronidase enzyme may end up relieving an entrapment. And another choice to try to manage this type of pain will actually be to do a neuroplasty, nerve release of the ganglion, just as we do for a nerve release for general peripheral nerve when there's pain resulting from nerve entrapment. CRPS type 2, which would have been called causalgia in the past, is a similar quality pain but arising from a nerve injury, also thought to be sympathetically mediated. Again, identifying the ganglion involved, carrying out ganglion blocks, hyaluronidase treatments, also stimulation. Implanted nerve stimulators may be helpful along the course of the involved nerve when placed proximal, or spinal cord stimulation. But these are always potentially very difficult problems. Some patients cannot tolerate surgical intervention in the presence of a CRPS problem. It will only aggravate the symptom. For this reason, surgery for CRPS is often discouraged. However, the incidence of aggravation of the CRPS from surgery in general probably runs in the range of 5 to 10%. So there's a much greater chance, if you have a properly targeted treatment, such as relief of entrapment of a ganglion or relief of entrapment of a nerve, that's in the situation of the entrapment causing the CRPS, it may be well worthwhile doing this to try to relieve the problem and resolve the underlying issue. General musculoskeletal pain can occur from nerve entrapment, particularly where the nerve is adherent to surrounding structures or mildly compressed. This is where a neuroplasty will often be successful in relieving the pain. This will tend to be more superficial pain, but also deep variations of pain with a sharp quality, soreness, aching, and usually not the superficial burning of the skin is more common with sympathetically mediated pains. One feature of sympathetically mediated pain is that there are physically observable manifestations of the pain, unlike more common pain. These will include changes in coloration, red to blue, also changes in temperature, warm to cold, variations of skin temperature. There can be, in more severe cases, some skin atrophy, loss of features, thinning of skin, loss of hair in the skin, as well as pallor or paleness developing in the limb. With CRPS type 2, it's even more common to see swelling from the nerve originating syndrome, and this is to do with vessel dilatation that results in edema. So this is a situation where edema can be caused by a nerve injury and can be resolved by treating the nerve injury. And again, blocks may be helpful to clarify that the swelling is a result of a ganglion irritation or nerve irritation. Also, hair loss can be a common consequence, as well as the redness, or erythema, and atrophy. Now, in this section, I'm going to run through some of the types of complications that can occur with common types of peripheral nerve surgery. So these are specific issues for peripheral nerve surgeons to be aware of. With regard to brachial plexus surgery, misdiagnosis of a rootlet avulsion, that is, believing that you have a more distal entrapment and failing to appreciate the presence of an avulsion driving the syndrome. Incomplete dissection or mobilization leading to incorrect identification of nerve elements. And these two first types of problems can often be avoided by the use of intraoperative stimulation. If you first place electrodes to monitor the various muscle groups, so that you can be quite certain of which motor components are present at a particular site where you're stimulating. Iatrogenic nerve injury during the course of the surgery, the biggest risk for the anterior approach to the brachial plexus will be a phrenic nerve injury. The phrenic nerve has to be carefully protected and should be checked intermittently during the course of the surgery to assure a good diaphragm response. Here again, if the patient is maintained under anesthesia without paralysis, it will be possible to have a phrenic nerve electrode in place so that the phrenic nerve can be readily checked for diaphragm response. Vascular injury during the course of the surgery. For this reason, some surgeons recommend having a cell saver present. If you're not extremely familiar with doing surgery in the brachial plexus because of the risk of a feared complication of injuring the subclavian artery with extravasation into the chest, for instance, in a difficult to access location. There's another good reason to have Satinsky clamps or other clamps that can isolate a vessel and allow for quick repair in the setting of rapid blood loss in the event a major vessel is injured during the course of the brachial plexus surgery. Vascular injuries can also include thinning or weakening a vessel that may subsequently bleed following surgery. When a osteotomy of the clavicle is carried out to gain better access to the mid or distal plexus, failure of the clavicle to achieve union after the surgery due to which can usually be accomplished by plating the clavicle, can lead to growth of a reactive fibro-osteo mass that incorporates nerve elements and moves abnormally with arm or body movements, leading to its own pain syndrome. The thoracic duct must be carefully protected during any brachial plexus surgery because of some right-left variance in the presence of chyle, as well as other lymphatic drainage elements inferiorly in the area over the brachial plexus proximally. These should be either very carefully coagulated in the course of surgery or carefully drawn out of the field of surgery to protect them. Hemothorax during the surgery, as mentioned, where you have extensive bleeding that you don't appreciate because the bleeding is going into the chest, and of course opening the pleura during a brachial plexus surgery. So it's well worthwhile to always have an upright sitting chest x-ray following a brachial plexus surgery. It is true that if the harm is merely to the external pleura, that placing a small valve may be sufficient to drain the pneumothorax overnight. It's a small amount without placing a chest tube. For the median nerve at the carpal tunnel, iatrogenic injuries include injuring structures that are relate to the median nerve but are not directly part of it. So, for instance, the recurrent thenar motor branch, because it originates in some variant locations. So instead of being directed towards the thenar aspect of the hand, it may originate on the hypothenar side of the median nerve and then curve back, so there may be unusual courses for the nerve. This can be injured during surgery. The palmar cutaneous branch is also readily injured during the initial exposure. The ulnar nerve in Guillen's canal nearby, which could be injured either by retraction or by misdirected incision. The distal arcade of ulnar nerve branches, the palmar arterial arch by going too far forward into the more distal part of the hand unnecessarily. Surgery that's a misdiagnosis, that is, the first and second digits are involved and a C6 radiculopathy is missed when there should be the first, second, and third digits from a median nerve involvement, as well as confirmation by, for instance, Tinel's at the wrist, electrodiagnostic confirmation by inching to clarify the precise location of an entrapment, or by MR neurography imaging to carefully evaluate the presence of an entrapment and the specific location of the entrapment. In some cases, entrapment is more proximal than typically expected, and therefore modified surgery would be required. Postoperatively, wound pain from healing in the hand. Sometimes there's an attempt to avoid this by using minimal access or endoscopic approaches. The endoscopic approaches have their own increased complication risks. Injury to the nerve during the surgery can result in a CRPS type 1. And finally, the decompression may be incomplete with persistent symptoms requiring reoperation. For the ulnar nerve, typical iatrogenic problems include injuries to the posterior division of the medial antebrachius cutaneous nerve, causing unnecessary numbness in the elbow, neuroma formation, recurrent symptoms due to persistent distal entrapment at the medial intramuscular septum, arcade of Struthers, and a variety of problems with transposition, injury to the branches of the nerves, as well as the development of symptoms that are triggered by extending the arm when the initial problem was symptoms triggered by flexing the arm at the elbow. For nerve sheath tumors, the ideal resection of a nerve sheath tumor involves identification of a safe entry point by nerve stimulation, working within the nerve, separating it from surrounding nerve elements, identifying the most minimal relevant fascicle that is involved in or already impaired by the neuroma without injuring adjacent salvageable fascicles. During the surgery, excess heat injuring uninvolved fascicles, and then retraction injuries affecting other nerves. This postoperative neurography image shows how you can investigate the development of symptoms following a carpal tunnel release. Here, the patient has suffered an injury to the recurrent branch of the median nerve. A typical MR neurography sequence will also allow you to see denervated muscle as hyperintense, and here we see denervation of the thenar musculature. You'll get a paralysis of some of the movements of the thumb, and these are quite difficult to repair, as it's a very small branch, and may lead to a very significant persistent disability. Here, the neurography can help clarify exactly what has happened. Perhaps there's a persisting entrapment that can be released with a direct inspection approach. In this section, I want to run through some of the different common types of nerve injury that can occur during the course of surgeries carried out by general surgeons, orthopedic surgeons, or neurosurgeons, or others in the course of a procedure directed to a particular structure where nerves are commonly injured and may require repair or diagnosis at least. During resection of a lymph node or biopsy of a lymph node, the spinal accessory nerve in the neck is commonly injured. And this may be misdiagnosed, but for diagnosis, you would be able to distinguish scapular winging from the trapezius weakness, as well as sternocleidomastoid weakness, depending on the location of the injury. The spinal accessory nerve is also sometimes injured during carotid endarterectomy, and the hypoglossal nerve can be injured during carotid endarterectomy, either being severed during the exposure or injured by compression in a prolonged carotid endarterectomy surgery, depending on retractor placement. Intraoperative stimulation can help avoid injury to these nerves during a surgery where a surgeon is at least aware of the potential for injury. The ilioinguinal nerve can be injured during open anterior hernia surgery or an endoscopic surgery with mesh placement, where the sutures that are retaining the mesh can incorporate and entrap the ilioinguinal or genitofemoral nerves. During hip replacement surgery, particularly with anterior approaches, there may be an injury to the sciatic nerve. During knee replacement surgery, the peroneal nerve may be injured. Also, gynecologic procedures where improper positioning can lead to an injury of the peroneal nerve. The ulnar nerve may be injured simply in a standard supine procedure where an object is present on the arm board, which compresses the nerve. And keep in mind that some of the gel pads that are used for padding can actually flow into the cubital tunnel and cause compression rather than protecting it. So often the best protection for the ulnar nerve would be a supporting foam where there's actually an opening in the foam where the ulnar nerve is exposed. This is also an issue in prone surgery, where the elbow is flexed on arm boards during surgery. Similarly, the median nerve can be injured in that prone position because of the hands down position on the supporting arm board. The brachial plexus can be injured, leading to a dramatic loss of movement and sensation after cervical spine surgery, which is quite alarming to the spine surgeon. The common cause of this would be failure to diagnose the presence of a thoracic outlet syndrome prior to surgery, and then during either an anterior or posterior surgery, The surgeon may tape down the shoulders to improve a cross-table lateral x-ray to be used for locating the level and confirming the depth of placement of an implant. In many cases, ties are placed on the patient's wrist and then traction applied to keep the shoulders out of view. But in the event that there's limitation or already pre-existing tension in the scalene muscles, the result is a brachial plexus impingement. If this occurs, the correct treatment will be to do a scalenectomy to resolve the entrapment. But again, neurography imaging can be quite helpful in understanding the type of brachial plexus distribution, numbness and weakness that can occur after the retraction for cervical spine surgery. The lateral femoral cutaneous nerve can be injured, leading to the syndrome often called neuralgia paresthetica, and this is a pain that's in the anterolateral thigh. One cause of this would be the iliac crest bone graft collection, where the course of the lateral femoral cutaneous nerve within the pelvis runs near the pelvic brim, and it can be injured in the course of harvesting the iliac crest bone graft. This can also occur in a prone surgery without adequate padding in the area of the anterior superior iliac spine, so that the lateral femoral cutaneous nerve is compressed during the surgery, leading to an entrapment that needs a neuroplasty. A common problem during gynecological sling procedures was the teaching that the sling could be placed and a suture used to secure the sling by passing the needle around the ischial spine in order to support the sling. Unfortunately, the suture may then capture and entrap both the nerve to the obturator internus, leading to a pelvic floor pain, and also the pudendal nerve, leading to very distressing dysfunction, pelvic genital numbness, urinary incontinence, and rectal incontinence. This can sometimes be treated by a posterior approach to the pudendal nerve at the ischial spine for a neuroplasty and release of the suture. The impar ganglion can be injured during spine surgery or gynecologic surgery, where the positioning results in undue pressure to the coccyx, causing a flexion, displacement of the coccyx, and compression of the underlying impar ganglion. The result will be pelvic and genital numbness, also potentially incontinence. And this can sometimes be resolved by doing a transcoccygeal surgery for neuroplasty of the impar ganglion if it will not respond to injections with hyaluronidase. We mentioned the accessory nerve and also hypoglossal nerve problems in relation to the carotid endarterectomy earlier. Another type of surprising injury would be during the course of an appendectomy or endoscopic intrapelvic surgery. A surgeon believes they have resected a lymph node, but in fact have resected the femoral nerve as it emerges between the psoas and the iliacus. And when the patient attempts to stand following surgery, a profound weakness of the quadratus femoris leads to knee collapse and often considerable uncertainty as to what is causing the problem. An extremely common problem for spinal surgeons is injury to the lumbosacral plexus during the course of extreme lateral approaches for spine fusion. Here, the issue is that by doing a very lateral approach going through the psoas, there's a good lateral access to the disc space. However, many spine surgeons have the view that it's impossible to know where the nerves are in this approach, and this is quite incorrect. As you can see from the image on the right, a good neurography image can show the exact location of the elements of the lumbosacral plexus relative to the intended course of approach of surgery. Retraction or direct injury during the course of transpsoas lateral approaches leads to an extremely high incidence of temporary or permanent injuries in the lumbosacral plexus, which can be resulting in more pain and weakness than the underlying spine problem for which the surgery was first directed. Preoperative MR neurography can precisely identify the safe course to use during surgery. Also, the use of retractors with electrodiagnostic capability, as long as the patient has no excess muscle paralysis during the approach, can help greatly reduce the risk of injury to the lumbosacral plexus, either by direct injury or by retraction. Here we see an unfortunate result of a vein stripping procedure where the peroneal nerve has been severely injured. Vein stripping involves gaining proximal and distal access to a dilated subcutaneous vein, passing a wire from an entry point at one end of the vein to where it's then recovered distally, and then pulling the wire down to strip out the nerve and strip out the vein and remove it. But in some cases, a vein will lead the wire into or through a nerve. Another type of vein stripping operation that can injure a nerve is a procedure using an endovascular laser, where the laser beam causes coagulation within an adjacent nerve element. Here the image shows vacuolation of the peroneal nerve at the knee during the course of a vein stripping procedure. The image at A shows the vacuoles within the peroneal nerve. An injury is shown at B. The nerve is resected. Here, an internal vacuole seen by caused by the use of a laser can be seen here in C, and then a graft replacement in D. This slide demonstrates resection of a portion of the accessory nerve during a lymph node biopsy in the neck with subsequent repair. A similar issue can occur, as mentioned in the list above, in the femoral nerve in an intrapelvic location during an endoscopic or robotic surgery in the posterior abdomen, where the femoral nerve is misidentified as a tumor or expanded lymph node encountered during surgery and resected, leading to a severed nerve that would certainly benefit from repair.